Hey, good morning, everyone. On this frosty morning, a lot of the U.S. is in for some big snowstorms today, so don't drive if you don't have to because it's crazy out there. Where I put down in the comments if you're watching live and you want to let us know how much snow you're getting or expecting in your area, how much you've gotten, go ahead and put it in the comments. I can tell you right now, we're looking at almost a foot of snow, they're saying, and we had the last storm gave us a foot of snow, so they've been pretty accurate so far. But who knows? It's the weather. Hey, if this is the first time you're watching us, we're not a weather station. We're education. And check out our website at UroNurse.com to learn more about us. Has all the information you could want to find out about all of our other podcasts. You can click right through from UroNurse.com to those. You can also see all of our great sponsors and check out their websites. And always check out our previous episodes. There's 174 episodes that'll be in there as of today. And also, everything comes out in audio form, so you're able to go and check that out if you want to listen to us on your busy commute. Great, do it. So let's get right to today's show because we've got a fantastic show for you. Today on UroNurse, we're joined by Todd Thompson. He's a highly experienced nurse and researcher with a deep focus on catheters, and he's almost a guru of catheters and urinary health. Todd brings expertise in the understanding the delicate balance of the bladder biome, shedding light on how the bacteria living in our urinary tract can both support health and contribute to disease. In this episode, Todd will guide us through the latest research on the urinary microbiome, explain how these microorganisms influence infections, inflammation, and overall bladder function, and share practical insights for patients and clinicians alike. Whether you're a healthcare professional or someone curious about urinary health, this conversation will help you understand how the microscopic world inside your bladder impacts your daily life. Hey, let's bring in our expert, Todd Thompson, and Lori Atkinson joining us today as our guest expert. Hey, welcome.
Morning.
Good morning. Thanks for the introduction. It actually makes me sound better than I am at this subject.
Oh, come on now. Don't be humble on me. You are the expert. So we're looking forward to your presentation. Lori, why don't you tell us a little bit about yourself for those that might not know who you are?
Sure. Good morning, everyone. My name is Lori Atkinson. I am a certified urology nurse. I have been in urology for over 25 years and currently practicing over in Geneva and Winfield, Illinois.
Great. And if you're new to the show, I'm Vic Senese. I'm the host and producer of UroNurse. Been doing this for quite a while, 174 episodes worth. And we do this every week, so tune in every Saturday to see more. And Todd, do you have anything else that I didn't say about you that you want to tell us?
No, I'm here in nice, warm Tucson, Arizona.
No snow coming your way, huh?
No, not at all.
So. All righty. I'm going to bring your presentation up and take it away.
Well, thanks for having me. I really started getting interested in the bladder biome because I was asked to do some work on CAUTIs, catheter-associated urinary tract infection. And that's kind of an old subject, and I kind of wanted to see where the new research is going and what's going on. And I have always been interested in the biome from the perspective of the biome of the bowel and the skin, but you don't hear too much about what's going on in the bladder. So I decided to try to see if I could pierce that subject a little bit. I usually like to start off with just a good understanding of anatomy and physiology so that we're all on the same page. It's always good to get a little bit of a update on that. And the thing that I really want to kind of focus on is that the top layer of the bladder is actually you can help me with the pronunciation of this, Vic, if I screw it up, but the glycosaminoglycan layer, and I'll just call it the GAG layer, which is actually a gel layer that is naturally occurring at the top of the skin, and it's actually creates a very good defense. It's a urothelial. GLG has a high density negative charge at the surface, which leads to a strong ordering of water molecules and puts the surface of the bladder into a gel. And the bottom line is that if the GAG layer is working properly, then it is a incredibly good defense against any infection entering into the walls of the bladder. Okay, so I think we need to remember that a urinary tract infection is not only pathogenic bacteria in the bladder, but it is also a destruction of the GAG layer and the underlying defense mechanisms that lead to that infection into the bladder. And I think sometimes we don't focus enough on the damage to the bladder wall. Underneath that is the umbrella cells, which are just cells that actually are designed to shed and close up in order to maintain a good barrier. And then we have the normal urothelium, basal membrane, interstitial layer, and then the detrusor muscles, which we're all pretty effectively understanding. Now, I've been doing nursing for a long time, and when I started in nursing, we actually were taught that the bladder was sterile. I was an Army nurse. That's where I started off being an Army nurse. And we used to be told that if you have to irrigate a wound and you're out in the field and in a battle and you run out of normal saline, you can pee on the wound and you can clear debris from the wound because urine is sterile. And, you know, I never thought I could do that because I have a little performance anxiety, and peeing in public in a battlefield just seemed like a little weird to me. But the truth is that, you know, this is how we believed that the bladder worked up until 10, 15 years ago. And this actually goes back to the 1800s, that when bacteriologists first started studying urine, they would seal it up in a container and it would not turn cloudy. So they believed that fresh, healthy urine was perfectly free from bacteria. And so that belief has actually been around since the 1800s. Also, our idea of a bacteremia and contamination goes back to the 1950s. That was done by a study where Dr. Cass, who was from Harvard, studied asymptomatic urine, and he only studied about 50 to 60 women in pregnancy, diabetes, and a cystocele. And he kind of came up with this arbitrary dividing line between what is considered bacteremia and what is considered contamination. So, you know, the idea of when you look at a culture insensitivity and you see, or I mean, a UA, and you see, you know, the bacterial load, and okay, this is contaminated, this is not contaminated, is a very kind of arbitrary old idea that comes back to the 1950s. The other problem is that we use kind of an agar plate, which is kind of the traditional culture and sensitivity. And agar plates are very limited in what they can do. First off, they have very limited nutrients. So not all microorganisms can grow because they may not have the nutrients that they need in order to effectively grow. Agar plates are also a very, very small plate. So if you have a aggressive bacteria that multiplies rapidly, it's going to knock out any other bacteria and not show what's going on. Okay. And we certainly know that an agar plate is not like the bladder. It's not like real world conditions. And so a bacteria that may be flourishing in the bladder or the urinary tract may not even pop up on an agar plate. Okay. And the other thing is that it's an aerobic environment. Functionally, our bladder should be anaerobic. So it's only going to grow things that are exposed to air. So we have this over reliance on this test that completely does not mimic what can grow in the bladder. One of the biggest differences that have happened recently is that we've developed different techniques to study bacteria. And the main one is that we have developed PCR amplification and RNA gene sequencing. And what that does is that they will actually extract urine from the bladder either suprapubically or through a sterile catheter, or they'll use different techniques to make sure that they're not getting any contamination. Then they put the DNA extraction under a laminar flow hood. Then they concentrate it and they measure it using a spectrometer. And then they use a purification kit in order to purify the final PCR product. Okay. And then they use that purified samples and do DNA sequencing under a MISEQ sequencer. Okay, so if you really want to know what's going on to the bladder, go ahead and ask your lab to do this for you, and then you'll really know, right? And this is showing a lot of different things. They also have another technique where they can use an enhanced quantitative urine culture, which is a little bit more common. And what they do is they actually draw a lot of urine out of the bladder. I think it's up to like 20 or 30 cc's. And then they put it on a variety of media and incubate it under diverse atmospheric conditions for 48 hours. And they can grow a lot more different cultures, anaerobic, things that grow on different media that would not show up on just a traditional agro plate. So when you start doing these things and you start studying bacteria in the bladder using these techniques, what do you think you come up with? Well, the truth is that this is how we should be viewing the bladder, not as a sterile environment, not as a clean room, but it's actually a diverse bacterial colony that interact with each other and work together in order to protect each other and protect the bladder. And, this is different than things that I was teaching 2 or 3 years ago. And so this has completely kind of opened up my eyes. So let's look at one study that was done in 2022 where they used PCR amplification and gene sequencing to see what kind of bacteria was actually living in a normal bladder. And they came up with over 150 different types of bacteria. And you can actually see, if you look in here, that E. coli and Enterococcus is actually on this, as well as a lot of bacteria that I had never heard of in my life. I actually had to look them up. And interestingly enough, I learned that if you're a really great bacteriologist, you can actually have bacteria that's named after you. So that's why you have things like Ezekiela and Janibacter and Johnsonella. Okay, I never knew that bacteria like this existed, but if you're pretty famous, you can live forever by having a bacteria named after you. They actually also have done studies where they compare the urinary biome in relationship to the gut and the urinary and the vagina. And you can see that there's about 150, if you look down in the bottom left-hand side, you can see that there's about 159 bacteria that were shared throughout the 3 different areas. Okay, they found over 459 species in the vagina, 1,484 in the gut, and 562 different bacterial species in the bladder. So, what we're dealing with is this intense interaction between different microbia in our body. And if you look at the picture to the right, which I thought was very interesting, that actually looks at the percentage of different types of bacteria, you can see that most of it is lactobacillus. And as we know, lactobacillus produces acid. It acidifies areas, okay, through fermentation. And the other thing is that as you get older, the lactobacillus amount kind of drops in all the different types of areas. Looking at the perineum, what I was actually really surprised at is that I didn't see E. coli on there. So we are taught that E. coli is like the major bacteria in the gut. And, I kind of walked around my hospital and I said, how much bacteria is in, how much of the bacteria in stool is E. coli? And most nurses would tell me 70%, 80%, 90%. When you look at a stool, you just think it's overrunning with E. coli. But when you look at these studies, you actually see that there's not a lot of E. coli. It actually falls under the unknown category at the bottom. Okay. which was incredibly surprising to me. And E. coli is actually a really interesting bacteria, okay? And it actually only makes up about 0.1% of the total gut microbiota. So think about that. When you study stool, you think that it's nothing but E. coli, but it's actually less than 1%, 1/10 of 1% of the gut microbiota. Now, in certain situations, it can flourish, but it is not an overwhelming bacteria. It's also a very versatile, metabolically flexible bacteria. That's why it can survive in different niches. It can be aerobic or anaerobic, okay? And it is actually one of the first bacteria to colonize the digestive tract of newborns after birth. And it is very important in the development because it helps develop vitamin B2 and vitamin K. Anyone who's done pediatrics knows that, getting vitamin K in a baby can be very important. Put them under the lights. Well, you can just give them a little E. coli, I guess. And the other thing is that it helps deplete oxygen along the GI tract, creating a hospital environment for anaerobes to grow. So without E. coli in our bacteria, then the other bacteria may not survive. But this versatility and flexibility is actually one of the reasons why it'll pop up on an agar plate more effectively than other types of bacteria, because when it's exposed to air, it can grow pretty rapidly. Looking further into E. coli, there was a study that recently came out in October of 2025, so it's brand new, that showed that actually about 1 in 5 urinary tract infections where they have E. coli is actually not from the poop chute. It's from contaminated meat. And this is interesting to me from the perspective that, we automatically assume that a catheter-associated urinary tract infection is from migration into the bladder, usually of E. coli. And, it could have been that they had some chicken or turkey that was contaminated, and that's why they've got a urinary tract infection. Okay, especially in low-income areas. I never kind of dreamed that E. coli would be coming from a meat oral source instead of a gut. So now that we kind of think about where bacteria plays a role in our bladder, and it's natural in our bladder, and that we have this GAG layer that helps protect the bladder, that we can have as much bacteria as we want in the bladder. And if the defenses of the bladder wall are working effectively, that we're not going to be having any infection, let's kind of rethink what we need to do about a urinary tract infection. And this is, I say COTI, but it's actually for all of them. So when you introduce a urinary catheter, you're actually doing two things, right? The main thing, I think, is that you can be causing mechanical damage and irritation to the bladder wall, which we have a tendency to discount. We have a tendency to focus on that it may introduce bacteria into the bladder. We're caught up into this closed system, sterile technique, all of these things that are built to prevent any introducing bacteria into the bladder. And we're not thinking about how the catheter itself may be causing irritation and damage. In my full study, I had some pictures of the bladder wall caused by introducing catheters. I didn't put it in this presentation. I probably should have, but I think that's a major issue. Okay. And it's that catheter surface and the damaged wall that actually allows bacteria to grow. And what we're actually doing is we're causing what I would call dysbiosis, which is a disruption in the normal biome. We're not introducing bacteria into the bladder as the main cause. We're causing a disruption. And it's the damaged wall that actually causes a route for infection. So that's basically what's leading to a COTI. And our goal should actually be more toward supporting the bladder wall and restoring the natural bladder biome, and not so much focused on trying to destroy all the bacteria in the bladder. Okay, because traditional treatments, which are things like antibiotics and bladder washouts, which is something that I'm very much against for any cause, are kind of like dropping a nuclear bomb in the bladder, right? We're not just destroying the bad bacteria, we're destroying the entire biome, and we're just wreaking havoc. And it can also, especially like vinegar, acid washouts of the bladder, you can be breaking down that GAG layer, which is actually making things worse. Okay. So, our treatment of the bladder is completely discounting maintaining the natural defenses and utilizing the natural biome in order to protect the bladder. So let's talk about what the improved treatment of the urinary tract infection, COTI or otherwise, should be. The first thing is, I think that we need to focus more on preventing the mechanical damage of the wall. Should we be using such a big catheter when we can use a small one? One of my big things is improved securement. You can have the elastic straps, and you'll have people that are pulling on their catheter or moving it around a lot, and that balloon hitting down on the trigon area of the bladder can be causing damage. And, you just basically are like bouncing around inside the bladder, causing a lot of damage to the bladder wall. I also think that there's a lot more issues with irritation of the bladder wall. I'm a big believer of silicone catheters. If you've heard any of my other talk, that, we have eliminated latex from every part of our tubes that go into the body, except for the urinary catheter. You don't see a G tube or any of those things, PEG, that is made out of latex. And why do we continue to have latex catheters? Just blows me away. And that is getting into removing the bladder irritants. It may not always be the catheter, or it may not be the bacteria, but maybe we have an irritated bladder. I'm always kind of caught between what we call an interstitial cystitis and what we call a urinary tract infection. And generally the difference is if something grows on a agar plate, right? But it may be that this irritated bladder is got a disrupted GAG layer, disrupted umbrella cells, which are leading to UTIs and pain and irritation. So a interstitial diet actually 50% of the time helps people with interstitial cystitis. So if we're getting rid of those irritants of the bladder for those, it should help with UTIs too, right? Decreasing dietary acid load, intake steady of water, just trying to eliminate anything that is hurting that GAG layer. There are also ways to replenish the GAG layer. There's some studies coming out about glucosamine, chondroitin, hydronolate, and cranberry juice or cranberry concentrate that have all been effective. And, we've heard of like cranberry being an effective treatment for UTIs at various efficacy. I actually, if people want to take cranberry, I recommend it. But I want them to take a high quality cranberry extract as directed on the bottle. Glucosamine and chondroitin are actually, we think of them for joint health, but they are actually some of the building blocks for the GAG layer in the bladder. So if we're increasing those in our body, it goes to show that we'll increase it in the bladder also. Estrogen replacement therapy has been shown to be very effective in rebuilding the GAG layer. As you get older, women have a higher rate of UTIs, and that is because the estrogen is not reinforcing the bladder wall. And then we have the intravesical therapy that can be used with chondroitin, hydronolate, all of these things that may have some effect in preventing UTIs that I don't think has been properly studied. The other thing that we need to consider is restoring the natural flora. So if you remember the study of the different bacterial biomes, so if we are able to improve the neighbor of the bladder, then it'll also help with improving the bladder. So improving bowel flora, vaginal lactobacillus suppositories can actually be very important at improving the lactobacillus in the bladder. You can actually get them on Amazon. Just go ahead and type in vaginal lactobacillus suppositories. They pop right up. They're not that expensive. You know, working to maintain a natural and normal urine composition that allows the bacteria to grow. And ultimately, I think that we're not that far away from considering urine transplants. I know that sounds a little bizarre, but you know, that is one of the main treatments of bowel health, is that when people's bowel biome gets really messed up, they actually will do stool transplants. And the same philosophy may be effective in the bladder. So a lot of these things are in the study phases or the development phases, and they haven't been completely worked out with good evidence-based studies, but they are really kind of the direction that we are moving. And just to kind of summarize, I think that we need to understand that the bladder is a natural biome that is protective. And if we're able to maintain the bladder biome and maintain the GAG layer, then we are going to do a much better job than just throwing antibiotics at the problem. And that, we're really talking about dysbiosis and not infection, if that makes a lot of sense. So this is a longer presentation that I cut down to 30 minutes. I wanted to leave a few minutes for questions, comments, complaints.
And probably all of the above. No, that was fantastic. One of the things that I thought I'd kick it off with is, you had mentioned, that thing about in the Army where they said urine we thought was so sterile. I'm one of the guys who's been around long enough to remember that urine sterile. But we did other crazy things. I just kind of dug this one up. So centuries ago, before modern lab tests, doctors noticed people with uncontrolled diabetes often had a sweet tasting urine due to high sugar. They actually tasted the urine to test for diabetes. And the old term mellitus meant honey sweet. That's why we got that term. So we did crazy things back in the day, right?
Mm-hmm. But, it's interesting that our idea of a sterile bladder goes back to the 1800s.
Yeah.
And we've just maintained that, and it's just been kind of like accepted as fact. And it's not fact at all. Our bladder is at a diverse bacterial area, just like the bowel or skin or any of the other areas.
Yeah. Well, and I think you hit on another good fact. You were talking about the bacteria. The way we're taught to put a catheter in was always, sterile gloves, sterile this, sterile that. And really research hasn't supported that.
No,
even there's some studies out there that show that using plain old water as a cleansing agent is as good as the betadine that we covered people from head to toe with.
And it amazes me even nowadays with the whole sterility thing, how people try to do cystoscopes sterile. And I just have never understood that,
So there's a question about sugar substitutes affect the bladder as it does the gut. I think that that's probably true. Again, we're not looking at a lot of evidence-based studies because we're in the new. One of the things that works in the bladder, I'm sure a lot of you have heard D-mannose, which is a type of sugar that is not metabolized the same. And the idea behind D-mannose is actually that it decreases the bacterial load in the bladder because bacteria will bind to the D-mannose in the bladder and be flushed out. So it is actually a good treatment for urinary tract infections, or a good supportive treatment, not a treatment. What's the word I'm looking for? Adjunct.
Yeah.
Okay. And I didn't put it into this presentation because it's not dealing specifically with the bladder biome, but it does have a role in decreasing bacteria in the bladder.
Yeah, absolutely. And, you spoke kind of a little bit about this, where we look at the dogmatic, theories that we've had. We've always done it this way. We always do it this way. And I think that you've been one of these folks that have kind of thought outside the box and said, wait a second, this isn't what we're looking at. A lot of symptoms, people come in complaining of frequent urination. They're treated UTI, put on an antibiotic. It's not always UTI. As we talked about, interstitial cystitis can cause frequent urination. Just bladder irritants can cause it. So what's really been kind of your go-to in evaluating somebody to distinguish between the two? Kind of whether it's truly infection, not infection.
I'm kind of struck by some of the arguments we've had at the SUNA conferences about how often does symptoms of a UTI resolve without any antibiotics, right? Is it the fluids that you're pushing in the person, or is it the antibiotic? At this point, what I'm doing is I'm trying to spend more time assessing the damage to, what can we do to prevent damage to the bladder wall? What can we do to improve the GAG layer, the defenses? And although I haven't, I still recommend, I'm not a prescriber, antibiotics. What are we doing on top of that to help prevent reoccurrence? What are we doing on top of that to strengthen the bladder wall and to improve the natural biome, and not just ignore those factors when we're dealing with a UTI? It's really hard to get away from antibiotics in our society.
I remember way back when, and you guys can probably appreciate this, where you treat a patient with antibiotics who are symptomatic, and they call, at the end of their treatment saying, I'm not better, I'm still having symptoms. We've changed a lot in our practice to say, it takes a long time, sometimes after the UTI has been treated, to get rid of symptoms because that layer is still damaged.
Yeah, absolutely. I'm going to bring in this one here. Question: are probiotics or targeted microbial therapies showing promise for improving urinary health or preventing infections? Is that any help for building up the bladder with the probiotics? Or
there are some early studies that, basically what you're doing is, if you're helping the neighbor, you're helping yourself. Okay, so improving gut health and improving vaginal health, if you have one, helps you in improving bladder health. So that's why there are some studies to show that the lactobacillus suppositories, vaginal suppositories, and just using probiotics in the gut can help. But remember, they're supportive therapies. They're not treatments. But, you've got to have a good neighborhood in order to have a good home, right?
Yeah. And I know we found a lot of these elderly women that were coming in with recurrent UTIs. We put on estrogen therapy, vaginal estrogen, to kind of restore the normal pH of the vagina, and boom, no more complaints. Did you see that in your practice, Lori?
Absolutely. They prescribe estrogen or estrase, however you want to say, estrogen cream all the time. And it's amazing, especially in those elderly women.
Right. And that's not directed at the bacteria. That's directed at improving the GAG layer of the bladder, right? You got good defenses. It doesn't matter how much bacteria.
Yeah. So now here's one that's for you. Looking ahead, how do you see microbiome science shaping the future of urologic care? Are we heading toward a personalized bladder biome treatment? It seems like everything now, it's personalized treatments. We're figuring out how to kind of treat you differently than Lori versus me. What do you think? Is there some that going to be, you'd even talked about inoculating the bladder someday?
Yeah, I think it's a brave new world, and it's going to be interesting to see where it goes. One thing that's big in Europe that isn't big here is vaccines. You don't see that too much in the United States, but they have, like E. coli vaccines that people use. I do think that we're going to see more biome therapies. This is actually such cutting edge, especially with the bladder. It's hard to see which way it's going to go. I actually remember when I was in elementary school, we had a science teacher that told us that pills were going to go away and that you would go to the pharmacy and get an individualized patch that could be made that you put on your skin once a week, that had all the medications in it, because the technology was being developed for transdermal therapy. And 40 years later, 50 years later, it's still not there. So we'll see where it goes.
It is a brave new world. And I think artificial intelligence is also going to add to how quickly we start discovering some of these things that we haven't been able to do with the human mind that can't crunch that many numbers at a time. Well, any other questions that you viewers might want, go ahead and feel free to put those into the questions. We'll be glad to take those in the comments. It's been fascinating to bring you on here again, Todd. Always just to kind of look at this whole situation of the urinary tract and things that we can do to prevent issues in the our own urinary health, and not just throw antibiotics at it, because that's not the cures to everything.
Right.
Although sometimes there's an appropriate need for antibiotics. There's no question about that.
I can't argue with that. But remember, when you are looking at a urine culture, remember the limitations of that urine culture. It's an agar plate, aerobic, and what you're seeing is what can grow on a urinary culture. On an agar plate, you're not necessarily seeing the big picture, right?
Right.
And it's going to take us years or decades to really figure out the big picture. But E. coli is incredibly effective at growing in an aerobic agar plate, not necessarily the causative organism of the symptoms.
Yeah. And the other thing I think is, and I kind of question, is with these newer urine cultures that came out that rely on PCR and DNA studies, are we overdiagnosing, or were we just finding things we were missing that we should have diagnosed?
We don't really know what's causing the infection. I do think that doing blood cultures maybe help us. But we're looking at data without truly understanding the dynamics behind some of that data.
Yeah. Oh, great. All righty. Well, I don't see any other questions coming in. I got some great comments that came in. They really liked you, as I would expect. What's not to like, right? I do want to bring in a little plug for next week's program, so hang on for that, and then we'll have some final closing thoughts. If either of you have something you want to say for the holidays or whatever, I'll be right back here.
In this episode, Vic is joined by Alex Hughes, lead nurse practitioner at Austin Urology Institute, to discuss aquablation therapy, a cutting-edge, minimally invasive option for treating benign prostatic hyperplasia. Aquablation uses robotically guided water jet technology to remove excess prostate tissue, precisely improving urinary flow while minimizing complications. This innovative therapy offers patients a faster recovery, less risk of sexual side effects, and a safe alternative to traditional surgical approaches. Join us on December 6th at 9 a.m. Central Time to learn more.
Yeah, join us next week to learn more. Todd and I were kind of chatting about in the beginning of the show before we got on the air. As we get to be this age, we talk a lot more about BPH than we did in the old days.
Yeah, it's a major subject for me right now. I'm moving in that direction where I'm probably going to need one of these procedures.
Yep. Actually, went to Florida a few months ago. My brother had to have a robotic open prostate because his prostate was so big, and it was symptomatic. It's like, well, I'm going to come down and take care of you. So he did really good, and he's now a couple months out, and he's like, oh yeah, he says, I got to watch how close I get to the toilet, or I'll be hitting the back of the bowl. So, I have bragged.
I remember those days.
Yeah, the good old days.
Yeah.
That's one of the good things about being a woman. One. We don't have prostate.
Yeah. All right. Lori, any final things you want to say before we go off the air?
Thank you, Todd. That was great. Be safe out there for any of you that are in our area.
Yeah.
Because but I'm grateful that it's not a work day, so we don't have to deal with driving in this.
I'm grateful every day's not a work day now.
Well, yeah, rub it in there, Vic.
Yeah. And Todd, any final words you want to say?
No, just happy holidays. And, studying this subject, you're really moving towards where the cutting edge of urology may be going.
Yeah.
So, try to keep up on this and it's going to be exciting to see where the entire biome studies go, especially with urology, because I think urology is actually a little bit behind the curve because of our normal
dogmatic practices.
Yes.
I always did it that way. I hear that so much. All right. Hey, I want to also invite everybody on at 10:30. If you go to UroNurse, you can get over to UroPatient. It's going to be the 100th episode of UroPatient, which I started a year after I started UroNurse. And so, a 100th is kind of a neat time to do a little celebration. So instead of being pre-recorded like it normally is, I'm going to have a live episode. So if you have questions you want to ask, feel free. UroPatient, was my thought, because UroNurse was getting so many people that are not healthcare, which is where it's really aimed, watching it, that maybe I needed to provide something that was aimed mostly at patients. So I did. I came up with UroPatient.com. It's all patient-based and aimed at patients. I have to tell you that even though it started a year later than UroNurse, the number of views have actually it's surpassed UroNurse in views. So there's a lot of people out there that are looking for information. So keep that in mind. Education is important to your patients. Make sure you're educating them. And hey, 10:30, feel free to join us and ask some questions. All right. I hope you guys have not too much snow. And I know Todd doesn't have any snow coming his way, but be safe. And we'll see some of you at 10:30 if you want to show up for that. Otherwise, we'll see you all next week for more about aquablation.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.